We're going to move on to our next presenter. Our last flash science presentation is from Dr. Neil Alexander. Dr. Alexander is the Ivan Duff Collegiate Professor of Geriatric and Palliative Medicine in the Department of Internal Medicine at the University of Michigan. He is the director of the Ann Arbor VA Healthcare System Geriatric Research Education and Clinical Center. He also serves as an adult falls content lead at the U of M Injury Prevention Center. He's the chair of the U of M Hospital Falls Committee and leader of the U of M Mobility Assessment and Enhancement or Falls Clinic. He's also the director of the U of M Mobility Research Center, which focuses on mobility in older adults. Dr. Alexander has a special interest in exercise, morbidity, falls, and rehabilitation in older adults. Again, please remember to type all questions in the Q&A box, and please welcome me in, join me in welcoming Dr. Alexander.
Hello, everybody. My name is Neil Alexander. I'm faculty at the University of Michigan in geriatrics. I'm a geriatrician laying hands on people. And I have a faculty position at the VA GRECC. And you see my co-leaders and co-authors here for this talk. I want to call your attention to Linda Nyquist, who's at the Institute of Gerontology. Dev Strasberger works with us, and Laura Ojeda, who's the engineer who is in charge of doing some of the fancy schmancy engineering stuff that I'm going to show you. The title of this talk is Detection of Real-World Trips in At-Fall Risk Community-Dwelling Older Adults Using Wearable Sensors. So the background to this talk is that losses of balance, which we'll call LOBs, are events where balance control is lost at least momentarily and lead directly to falls. The mechanisms underlying LOBs and unsuccessful recovery is a fall, but successful recovery, we've not studied them in the real world very carefully. Few studies explore the biomechanics of real world LOBs and falls, and they frequently focus on continuous walking. So fall studies rely on delayed, potentially inaccurate post-fall self-reports regarding the context and the intrinsic and extrinsic circumstances of the fall. Intrinsic are things in the human body, and extrinsic are like environmental parts. So virtually no studies link these biomechanics to the context, like what's happening around the time in the environment when the loss of balance occurred, or LOB. Our study goal is to investigate real-world trip responses in at-fall risk community-dwelling older adults using inertial measurement units, IMUs, and concurrent patient reporting of the context of a trip. So I'll use that term LOBs and IMUs. The inclusion criteria are independent community-dwelling older adults aged 60 or over without cognitive impairment or assisted device dependency. They've had either 2 or more falls in the last 6 months, and injurious falls in the last 6 months, or self-reported balance or gait difficulty as per American Geriatric Society guideline. This basically is an at-risk group. That's what I mean by at-risk. They have to fulfill one of these 3 criteria. The design, I don't know if you can see that at baseline, they have an orientation to how to do the LOB reporting and some mobility assessment, which I won't spend a lot of time on today. And they have a run-in period for the LOB reporting using a voice recorder, which I'll show you in a moment. And then we actually come back to the lab, we get a debrief, and they actually and instruct about the motion sensors for a home training or home evaluation for the last 2 weeks, for weeks 2 and 3. So basically, what we want to do is basically monitor them with these motion sensors, these IMUs, and we have a voice recorder that they're going to wear on their wrist, which records the context of what's going on at the time they actually have a loss of balance. And I'll show you that in a moment. So these IMU sensor setup is 4 IMUs, one mounted at the feet and the lower back, and one at the wrist. Look at the dashed yellow line. You see the dashed line of the one at the wrist, one at the back, and the 2 at the feet. And then there's a dashed red line which shows the voice recorder worn on the other wrist to provide a record of context and timing of the LOB event. The analytics, where we have trip identification. So events that are reported as a trip by the participant on the voice recorder and identified as a trip by an observer of the IMU record, blinded to voice recordings description. So this is IMU objective information, which is directed to some extent, or it's directed by the voice recorder. The data processing of the IMU is a 10-minute window of the IMU data prior to the timestamp voice recording of the trip. In other words, we have a voice recording. It tells us they lost their balance, and we back it up 10 minutes to see what actually happened before that. And then the elegance here of an animation model where you take the feet, lower back, and wrist position and orientation to create an animation representing an estimated body viewed using a motion and animation visualizer. I'll show you that in a moment. And this is based on a paper we published a couple years ago, based on leading work by Laura Ojeda, our engineer. Trip characteristics that we note are things like deviations from the stereotypic pattern of foot trajectories during normal gait, like examples, a sudden change in rhythmic foot speed, greater 2 or more steps performed with the same leg, simultaneous non-zero velocity of both feet at once, and also there's sudden changes in the lower back and wrist position. And again, this is, I'll show you some examples of these, and this is as per a paper that's now in press. I didn't mention Shirley Handelsaltz, who was a visiting postdoctoral, actually doctoral student, but she became postdoctoral at that time from Israel, who actually is the lead author for this work. So the participant characteristics are, I'm going to show you data on 5 participants. 4 male, 1 female. A number of them have had falls in the past 6 months. A few have had injurious falls. The ABC score says that the activities balance confidence. So how comfortable they are, how confident they are that they can maintain balance. A lower score is worse. So people less than, let's say, 65 have some sort of problem. So you see an 81 there and a 76, not so bad, but the other 3 they have concerns about their balance and confidence. 1 actually uses a cane. The timed up and go test is the ability to get up out of a chair, walk 3 meters, turn around and sit back down on the chair after walking. And you see that the number of 13.5 is really a cutoff of some impairment. So some are a little slow. Some are actually in that range of very close to being an impaired or at-risk group for fall. In other words, I'm trying to make a case that this is an at-risk fall group. So this slide shows our first participant and shows the descriptive kind of the context. He caught his left foot under the carpet and stumbled. This was in the home in the hallway. And you see here in the last orange column which IMUs signals were used to determine what this loss of balance looked like in terms. And you can see that the trip foot and the lower back were the ones that were involved. And so that comes very clear here in the first figure there you see of the feet. You can see where the arrow is. That's where a lot of the information that we use to determine the trip came from. In the next slide, I'll activate the actual kinematics, kind of the animation reconstruction of the trip. Call your attention to the left foot there. That was the trip right there. Let's show you that one again. There's the left foot. There you go. So that's the power of this animation, kind of helps you reconstruct to kind of really get a sense of what the whole body is doing. The next example is participant 5, stumbled going upstairs and tripped. Was on the stairs at home. Again, the tripped foot and the lower back IMUs were the ones that were critical to understand this trip. And you can see the feet clearly, one of the feet clearly had a problem. And now I'll show you the animation. There's the right foot. Now remember, they're going upstairs, so the feet kind of look kind of funny in terms of configuration. I'll show it to you again. There you go. The right foot. So the challenges and possible solutions for this work, some of the LOBs may be undetected or unreported. And so one of the things we're trying to do is we're working now with data science and other engineering people to develop a machine learning algorithm for automated screening and analysis. The other thing we've been criticized about is that you're dependent upon the observer to determine and acknowledge the loss of balance. So that automated screening analysis might help. On the other hand, there's a challenge of the voice recorders needed for the context. And so I don't know if these automated screening and analysis algorithms will ever replace the inferences that you can get regarding context from a voice recorder. There are other issues we're trying to solve, such as the optimal number of IMUs for analysis, what number is feasible. And particularly, these losses of balance are detected during the day. So non-daytime losses of balance are particularly important. We just don't have the battery life and the context right, or the methodology right now to get that done, but we're working on that. Future IMU issues and studies, adding a lab mobility battery to determine the extent of impairment of their mobility and how that might lead to an LOB. A prospective field study of the IMUs with voice recorder and look at not just LOBs, but also fall incidents. And future customized fall reduction programs to include task-specific training to improve safety of routine functional mobility, heightened awareness of balance control limitations, and guidance for environmental modifications. Again, based on what we could see, based on the tracing and based on the reconstruction of the animation, kind of get a sense of what this particular participant or patient would need. I want to acknowledge the funders, of course, the Center for Disease Control, but also the Older Americans Independence Center from National Institute of Aging and MISHAR for their support of our work. I'm available now for questions and answers. Thank you very much for your attention.
Thank you so much, Dr. Alexander, for that really great presentation. This is really innovative work that you're doing on reducing falls among older adults, and it's so interesting to hear about it. We're getting some questions that are coming in the chat, and one of the people is asking, what are the implications of your findings, of these early findings for clinical practice?
So that's a great question. So right now, all we have are fall reports. If somebody falls down, they have to tell you that. And so we're looking for think of it as a Fitbit for falls. And I think that's where we're coming toward right now. We'll have some sort of device that'll be able to tell us, first of all, if they lose their balance, and second of all, if they fall. But some of the fall stuff is already available, like on a iWatch, for example. I'm not sure exactly what the algorithms are, but if you want to know more about how people actually maintain their balance and how they're actually being able to negotiate their environment, which we call context. I mentioned the context issue. We need stuff like this. We have nothing like this right now. I think we're going to be able to measure context better, measure what's really happening with people when they with a near fall situation, that puts them at risk for future falls. Because otherwise, we have nothing right now. Literally nothing of what's happening. There are some video. There's some video work that's been done nationally or internationally, but not like this, because it has these devices that are downloadable. We're talking right now. Actually, we're actually talking to ways to upload this into the cloud to actually have this in a real-time version that we can actually watch people, not watch people in the sense of watching their bodies, but they're visually, but watching the tracings of their body movements.
Right, so you can see loss of balance early before they fall.
Yep.
Yeah, that's a really interesting sort of interdisciplinary partnership, it sounds like, between engineering and clinical and public health researchers. That's cool.
That's correct.
So it's come up a lot today, but someone's asking about COVID-19 pandemic. Like, what are you seeing on older adult falls in the hospital related to this sort of new situation?
Yeah. So the thing about COVID, let me say a couple of things. First of all, I am not aware of a lot of falls data in community-based falls data that's been affected by COVID. So we know that activity has been curtailed. And so if you don't have activity, you don't have falls. If you sit there and do nothing, you're not going to fall down. On the other hand, you're at risk for future falls because you're more deconditioned. So we might expect something later. Now, the big issue right now for COVID-related falls is long-term care, but more particularly in the hospitals, where we've gone up, we have PPE on, and then somebody's trying to launch themselves out of bed. And so that the standard protocols to do falls-related fall risk reduction is difficult now because of that barrier, the PPE barrier, and the infection barrier that's there. And I'm not sure that's been solved. A lot of this comes down to, by the way, something we may or may not have discussed very much, is cognition, is how well people are aware and behaving in such a way to be safe. So that's particularly true in the hospital, where somebody might be confused or have delirium related to COVID. They don't understand they're not supposed to launch themselves out of bed. And then the nurse is outside the door and trying to rush in there with PPE. There's been several cases of that. Data is hard to come by so far on that, but that's what we're seeing out in the field.
Mm-hmm. And our last question that sort of come into the chat is, in the literature, there's a substantial focus on acute falls. And from your work, it sounds like we have just as much to learn from near falls. And if so, what research do we need to do to learn more about that?
So that's a great question. So let me restate the question in a different way. So we're looking at, I would call recovery responses, early near fall responses. And we don't know anything about that. We don't know anything really what happens about later fall responses, which then ultimately where they go to a fall. And then there's another piece of that is how to when you have an imminent fall, what do you do then? So I have a group that I'm working with, and they're in Illinois now, but soon to move to Kansas, that are looking at training people to keep themselves from having an injury while falling. It's basically a tuck and roll strategy. And I'm not sure we're going to have our frail 80-year-olds doing this, tucking and rolling and practicing this. But if something had begun early on as a public health type of thing, and people in their 50s and 60s that learned how to do a fall response and learn how to decrease impact, that would be the kind of acute fall kind of paradigm that I'm talking about.
That's interesting and makes sense. Well, thank you, Dr. Alexander, for this wonderful work and for coming and presenting today.